Good evening, everyone. Now that you're all settled, we'll get started here. So I want to welcome you to the Snyder Institute's Mini Medical School Lecture Series. We're pleased to host a presentation and discussion this evening on the topic of artificial intelligence in medicine. Before we get started, I'd like to go over a few housekeeping items. There'll be two parts to tonight's program. First, each of our presenters will speak for about 20 minutes. Then we'll open the floor to audience questions. Following the Q&A session, there will be an informal reception for those of you that are here in person. You're welcome to ask your questions at any time during the presentations using Slido. To access Slido, you can scan the QR code or manually enter the event code Snyder MMS into the participant field on the Slido website to post your question. Questions submitted to Slido will be viewable to all audience members, and participants can upvote the questions they most want to see asked. Now on to more specific housekeeping items. For those of you that have joined us online, if you lose your internet connection and drop out, you can return to this session using the same Zoom link you used to join us now. If you experience any technical issues, such as you cannot hear or see the presenters, please email snyder@buxa.com and our team will do their best to support you. For those of you here in person, we now ask that you switch your cell phone to silent. Please note this event will be audio recorded and the recording will be posted on the Snyder Institute website and YouTube channel. Private recordings are not permitted. Now to formally begin tonight's program, the Snyder Institute at the University of Calgary's Cumming School of Medicine, located in the heart of southern Alberta, both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Blackfoot Confederacy, comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Bearspaw, and Goodstoney First Nations. The city of Calgary is also home to the Métis Nation within Alberta, including Nose Hill Métis District 5 and Elbow Métis District 6. Now, without further ado, I'd like to introduce our first speaker, Dr. May Choi, who's a rheumatologist and clinician scientist who joined the faculty at UCalgary's Cumming School of Medicine in 2020. She's an early career investigator, and her research is focused on biomarker discovery and validation for prediction of clinical outcomes in autoimmune rheumatic diseases and the prevention of autoimmune disease development and disease-related complications. Her background and training include a Master's of Public Health in Epidemiology at Harvard University and a lupus fellowship at the Brigham and Women's Hospital. Dr. Choi is also the Associate Director of Nitrogen DX Laboratory for Novel Autoantibody and Biomarker Testing for Autoimmune Diseases and the Associate Director of Research for the University of Calgary Lupus Center of Excellence. She is funded by several career development awards, including the Helios UCMG Post-Fellowship Training Award, Dr. Subrata Ghosh Fellowship Award, and the Lupus Foundation of America's Gary S. Gilkison Career Development Award. She also received a CIHR project grant in her first year as an early career investigator. Welcome, Dr. Choi.
Can everyone hear me? So good evening, everyone. As Hannah introduced, my name is May. I am a rheumatologist and I'm also a researcher at the University of Calgary. And I'm really excited to talk to you today about AI. I think it's a really, really big topic. So hopefully I'm able to touch upon many things and give you an example of how it's being used today and potentially in the future. So these are my disclosures, none of which are relevant to today's talk, but my biggest disclosure is actually, I didn't know if Hannah was going to reveal this, but I'm married to the co-presenter. Totally by coincidence. But I had to say it because he may be included in some of my slides with consent later on. So it's really a warning for him. So the objectives of my talk. So the first part of my talk is to explain to you what generative AI is. And there are many different types of AI, but I think Gen AI is really topical right now. Everyone's heard of ChatGPT, so I think it'd be a really good opportunity to talk about what that is. I'm just gonna go back here. And then to use lupus as an example of how we can use Gen AI to manage our patients. And then lastly, to talk about some of the opportunities, but also some of the challenges that we may encounter with using this type of technology in medicine. So if everyone can pull out their phone, scan this QR code, or go to slido.com and enter this number, I would like you to answer the very first question, which is, when do you think AI will be replaced by MD intelligence? Is it 10 years, 50 years, 100 years, or never? So I'm just gonna look at some of the answers right now. So it's pretty good split right now. It's 45% 10 years, 44% says never, ever, 11% said 50 years, and 2% said 100 years. So it's actually split pretty evenly. So I'm actually quite pleased to hear that some people actually think it's coming very soon. And if you don't believe, it's going to be sometime in the next 10 years, some people like Bill Gates really think that in the next 10 years, many doctors and teachers will be replaced by artificial intelligence. He thinks that the reason why this is because AI and intelligence will be freely available to us. It will touch everything that we do in the future. About 5-6 years ago, he predicted that today we would be in an AI revolution, and that's certainly where we are today. So he's been point on with his predictions. And even the doctors think they will be replaced. So I gave out this survey last year to about 400 students who are training to become rheumatologists, and 60% of them think that they're going to be replaced. It was pretty depressing. But we're going to talk about some of the potential limitations. So AI is so popular right now, the next generation of kids born after 2025 may even be called Generation AI. So we have TV, radio, TV, computers, internet. The next generation will be impacted greatly by generative AI, and we'll talk about what that is. So actually, AI has been around for a very long time. The first paper that came out talking about AI was in the 1950s. So this was the very first paper that coined the term AI. And you can see at the very beginning, the number of variables, so information was, just like around 10, 15 variables. But over the span of, all the way up to now 2020, it's reached 1 trillion parameters. There's really been an exponential growth in how much information our models can handle. And that's because of our ability to collect lots of information, so big data, and also supercomputers. So these computers are powerful enough to analyze that information very quickly and efficiently, such that GPT-4, you may have heard of, can now process 1 trillion data points, and GPT-5 is even more, but they don't really release the numbers. So we can probably say it's more than 1 trillion. Probably in 2030, we'll reach the human brain capacity at 100 trillion data points or variables. And if some of you may remember, back in 1997, AI already beat the world chess champion at that time. Do you remember IBM Deep Blue? Some of you nodding? So we're clearly going to get there someday. And it looks like it's going to happen faster than you think. So the next question for you. Have you used ChatGPT or similar AI tools to help answer a health-related question? Yes, no, or you really don't want to say because you don't want your doctor to find out. So most people are admitting it. Yes, they have. Myself included. Next question. How familiar are you with these algorithms? Very familiar. You basically work at Google and can code. B, somewhat familiar. You know just enough to be dangerous. Not familiar at all. It's basically like magic. Or D, who cares? I don't need to think now. So looks like I need to advance. That's right. So let's just show the raising your hand. So who thinks it's A? You're very familiar? Okay. Wow. I'm pretty confident people out there. B, somewhat familiar? Nice. Okay. C, not familiar at all? Okay. And D, you don't really care, just, oh, okay. So most people actually really care. Good. Excellent. So the answer is probably, even the experts out there, don't know exactly how it works. There's a reason why they're called black box models. It's really magical, actually. GPT-4, though, has been thought to actually have read the entire internet and memorized it and analyzed it in the span of 3 months. It's read all the images, all the scientific papers, the web contents, books, conversations. It's done that in 3 months. It's memorized 10 trillion words. And the thing that makes it special is that it can handle context. So a really good example, I have 2 kids at home. You know, a couple years ago, they're 3 and 4. So a couple years ago, you were having some conversations. They would, spit out like phrases, like, great, good job remembering. Now they're getting to the age where they remember things. They remember mom promised that they would be able to watch TV the next day. The conversations are a bit more meaningful. So it's kind of like this version is becoming more sophisticated. You're actually chatting with AI and the conversations actually make sense. So that's the power of ChatGPT. But Gen AI is just really a type of machine learning, which is a type of artificial intelligence. And you can see again, it's really been here for a long time. What makes Gen AI special is that it can generate new content. So the question as a rheumatologist and as a researcher who uses AI, how can we improve lupus care using this type of technology? So first of all, what is lupus? Most people have not heard of this condition. It is relatively uncommon. It is a chronic autoimmune condition that can affect any part of your body, which makes it very difficult to recognize. Symptoms are often invisible and very nonspecific. I have some patients who have arthritis and a rash. They have lupus. I have some patients who don't have those symptoms at all, but it is in their kidneys. They also have lupus. I have some patients who have seizures, psychoses. It's in their brain. They also have lupus. It's very, very challenging to recognize. And most of my patients are young women who are just starting their families, just starting to have their career. So it's a very, very critical time point. And most of my patients are actually non-white, which comes into play later on where I explain why AI really is important to consider ethnicity and race in this. So lupus is a leading cause of death, especially among young women. It is the number 7 leading cause of death among females 15 to 24. And that statistic is even worse if you're a Black or Hispanic. Number 5 leading cause of death. And often my patients of non-white background have even more severe disease. So they are the patients who go on to dialysis. They're the patients who have brain involvement. And often the journey to get to see a rheumatologist is a very long one. So this is an example of a patient of mine who was born in 2003. They started to have symptoms when in 2015, but it wasn't until 2018 that they finally saw a rheumatologist. But in the time to get there, they actually saw many doctors, went to the hospital, had many tests. Finally, they were started on medication, and then they were enrolled into trials. They're enrolled into projects and studies to understand why they developed lupus. So often the path is not very straightforward. And to this day, lupus is a disease that is still associated with high morbidity, disability, and mortality. Some organizations call lupus because we still don't understand what causes lupus, and many of our patients are still suffering. So can AI solve the cruel mystery of lupus? So let's break it down. Can we improve the diagnosis and recognition of lupus using artificial intelligence? So you may ask, well, is AI smart enough? So there's actually evidence that Gen AI can already pass the board exam. So in this study that was published in a reputable journal called NEJM, it showed that it passed 4 out of the 5 exams, including internal medicine, which is what rheumatology is in. And if you look at the scores, it actually surpassed many of the physicians who took the test. So the one in blue is GPT-4, and the ones in pink is the physicians. And then the one in green is GPT 3.5, which was made public just like a few months earlier than GPT-4. But you can see, even within that time frame, how much better the next version of GPT got. So that's how fast our AI models are learning and how fast they are improving. That's really scary. Okay, so you say, well, maybe the exam was too easy, too basic. But actually, there's the studies to show that it can even solve the hardest cases. So NEDGEM, again, this scientific journal, they love to collect some of the hardest cases that physicians see in the world. And they collected 38 cases and then challenged ChatGPT to say, can you solve the case? So it actually solved 57% of the cases compared to human readers, so the people who subscribe to this journal. Only 36% of them got it right. So 11% of these were rheumatology cases out of the 38, which was of interest to me as a rheumatologist. And then I tried out some of them on my own. I won't tell you how I did. But let's just say I was very impressed. So GPT-4 not only got it right 57% of the time, but it did fast. Like within a second, it could tell me what the right answer was. For me, I had to read the 2-3 pages for each question, think about it. It took me on average like 5 minutes. So, the other thing that was really interesting is that GPT-4 is not really designed to answer medical questions. And there are ChatGPT-like tools out there that have been trained on just medical data. So the fact that it could just do this and not to look at medical information was also very impressive to me. So that wasn't good enough for me. I said, okay, let's do like a real life situation. So I kind of like based it on my own experience, came up with a case that was realistic enough. And I said, what would you do in this situation? So I said, this is a 42-year-old lady. She's got lupus. She's got these symptoms. She comes into hospital. She's in heart failure. There's inflammation all around her heart. She's in the ICU. These are the medications she's on. What would you do next? Within 1 second, it gave me this very comprehensive answer. And it said, do you want it in a chart? Do you want it in a table? Do you want it in a picture? Wow, this is amazing. And then I looked at the answers it gave me, and it was actually not that far off. I would say that I gave it a B+, and I think maybe it could have done better if I gave it a bit more information than that sentence or 2 sentences that I gave it. And then the ones that are in red are things that actually happened to the patient. But that was because, like these ones in red, I actually asked experts around the world. And maybe GPT-4 didn't have access to that information that I had to solicit from physicians through meetings and things like that. But it was actually not that far off. And for a very, very complex case, I thought it did a relatively good job. And it did that all in the span of like a few seconds. It was pretty impressive. I showed my residents this. I said, guys, look, AI can do this. That's the thing. No, I'm just joking. So day-to-day stuff for a physician, Dr. Ma will talk about that. But for patients, actually, there are now chatbots that are designed to answer patient questions. Oftentimes, when a patient leaves my office with a lot of questions, and sometimes the things that I say don't make sense. I use maybe some medical terms that they're not familiar with. There's actually chatbots and AI-like tools that can translate all of the information that the physician gives them into language that they can understand. Some people actually type in their symptoms in these chatbots, and it gives them responses, and again, in a way that they can understand. It's actually a really important tool, I think, for patients who live in more remote areas that may not have access to rheumatologists and other types of physicians. It's interesting because if you look at social media, there have been people who've claimed that the chatbots have helped basically save their life. They said, I have these symptoms, and they said, you need to go to Emerge right now. You're having a stroke. Or, this other case that was a TED Talk where the patient had seen like 13 different specialists, and the only person who solved the case was AI. So there's anecdotal cases of how it's been useful. But I can see the advantages of having this kind of tool for the patient. And there's even chatbots for lupus. So this chatbot is specifically designed to help lupus patients, and it was actually nominated for an award. because of how useful and how reliable the tool is. Can you use it as a way to help treat patient symptoms? So in lupus, depression, anxiety is very, very common. And so this is a clinical trial looking at having patients use an app for 4 weeks that helps treat depression and anxiety. And then after 4 weeks, they re-examine how these patients did, and then they look at these patients again in 8 weeks to see if it improved their symptoms. And that's exactly what they showed. These patients using this AI chatbot app that talked to them every day, that the rate of depression and anxiety and feeding and eating disorders actually decreased after treatment. So you say, well, AI can never replace physician empathy. They're just robots. They don't have feelings. So in this article, what they did was they looked at a public forum where patients would post their questions, and then they looked at the physician responses and then compared it to the AI response. And what they found was actually the AI was 10 times more empathetic than the human physicians. So in this graph, the chat box is in the gray, physicians are on the left, and the further you are to the right, the more empathetic you are. To the left is less empathetic for that one. And then this is good and very good. Sorry, very good and very poor. And you can see that chatbot had higher quality and more empathetic responses. So I was curious to see what kind of questions. So there was one question from a patient, it's oh my goodness, I just splashed bleach in my eye. What should I do? The physician said, I think you'll be fine. If you're not, call this poison center line. And then the chatbot said, I'm so sorry to hear that this happened to you. This is what I would recommend. And it was the 3-paragraph answer. So anyways, so there, in this study, they showed that potentially AI may be more empathetic. What about research? Can AI actually think of creative and novel ideas? So here's a study that shows you that AI can actually be creative in thinking. So in this study, they asked a bunch of researchers to think of new research ideas and asked AI to do the same thing. Then had a bunch of reviewers blinded to whoever wrote what to rate those questions. And what they found were the AI research ideas were more exciting and more novel than the human researchers. So the light blue is AI, and then the yellow is human. And AI is definitely integrated in research and medicine in many different ways now. The integration of AI is just exploding. And even just you can see in the last 10 years, exponential growth. And lots of different questions are being explored. Diagnosis, outcome, complications, treatment. And I just wanted to mention, quickly, because I think I'm running out of time, but I just want to mention that there are also limitations to using AI. So think about collecting all of your information, what that has potentially on confidentiality, privacy, patient consent. There's some hospitals that are now thinking that the moment you step through the door, they collect your information. That information is then used to train an AI algorithm that will then be applied to the next patient that walks through the door. So did you know that they're doing that already? Did they actually have your consent to do that? Some AI algorithms are built in very specific, are tested and developed in a certain population and then applied to another population. So is it actually generalizable? So for example, in lupus, which is more common in ethnic minorities, if your algorithm was actually based on a population of mostly white patients, is the app actually applicable to the disease that you're talking about? I would argue not. So you have to be very careful when thinking about how you are applying these algorithms. Most of the algorithms are out there are actually not validated. They have not been tested in another group and are not FDA approved. So despite all these research and all these algorithms, only just over 1,000 of them have been approved by the FDA. So we talk about privacy and confidentiality. All the information that you put into these AI tools could potentially be used to train the next iteration of that tool. There are ways that you can try to turn on the privacy, but that data is still stored and potentially shared with other businesses, the government, other users. So your information does get out there and potentially could be shared with other people. You may have heard of AI hallucinate. So if AI doesn't know the answer, it could potentially make something up. Or another term that's becoming more well-known is sycophancy. So AI doesn't think that the user will like. So they'll bet on the truth. So a really good example is like training my husband to know what I like to hear. It may not be correct, but he knows that he wants to tell me what I want to hear. So that's sycophancy. And the last thing I want to tell you that you may not have thought about is the environmental impact. So did you know that if you type ChatGPT, please do this, please and thank you, that it actually costs millions of dollars for this company? Why? Because it's energy. It takes a lot of energy to run these models. So GPT-4 took 25,000 GPUs. So you see that's like 25,000 computers running 24/7 for 3 months to train that model. And our models and our data is only getting bigger. And some of these data centers use more electricity than entire countries. And with that, you need water. So to think about it, every time you enter a request on GPT-4, that uses a bottle of water. If you ask it to write an email for you, that's 3 bottles of water. So it's a lot of electricity and water. So although we want to help our patients get from point A to point B very quickly, you have to be careful to make sure that that process doesn't get more complicated than it needs to be. So definitely Gen AI is becoming exponentially more integrated in medicine, but as physicians and as patients, researchers, we really need to stay informed of how we're developing these tools, what is the power, but also the limitations. And we are in the AI revolution. So this isn't the time to be sitting back and just watching as these tools come out and use them. We really need to be actively involved in how they're being developed and how we are going to use them to manage our health in the future. So with that, I don't know if that still changes your mind. I don't know if you have time to answer this question. But I think it is coming. I wanted to just also to put in a plug for my lab, which does use AI. If you want to learn more about what we do, here's a QR code. With that, I think I'm going to invite Dr. Ma to come up and give us a talk. Perfect. Thank you. Thank you for coming.
All right. Thank you so much for the wonderful presentation, May. I'd now like to introduce our next speaker, Dr. Chris Ma, who's a gastroenterologist at Calgary's Cumming School of Medicine. He completed advanced clinical fellowships in inflammatory bowel disease at the University of Calgary and Western University, as well as formalized research training in clinical trial methods as the 2018 Robarts International IBD Clinical Trials Fellow. He received his Master's of Public Health in Epidemiology and Biostatistics from the Harvard T.H. School of Public Health in 2019. His research portfolio now focuses primarily on clinical trial design and analytic methods and the epidemiology and treatment of gastrointestinal diseases. Dr. Ma has published over 250 peer-reviewed manuscripts. He's the lead for the International CORIOS and Core IBD Consortia, has been awarded over $7.5 million in peer-reviewed research funding, including from CIHR, the Canadian Association of Gastroenterology, and Canadian IBD Research Consortium, and the Helmsley Charitable Trust. Welcome, Dr. Ma.
Thank you very much, Hannah. That was written by ChatGPT. Thank you very much, everyone, for coming out tonight. It's a real pleasure to give a talk with my wife. She made me say that before I came out. But I thought I'd talk a bit about when you'll have an AI gastroenterologist. And so maybe after the last talk, it might not be that far into the future. She doesn't know that she's my backup plan. So yeah, I still have hope. I think maybe what we'll do tonight is talk a little bit about from my perspective, where we use AI currently, where we use it in our day-to-day practice, where we use it to be better gastroenterologists, and whether or not a future with an AI gastroenterologist is going to be better, worse, or about the same. So hopefully it'll be engaging, and hopefully it'll stimulate lots of questions for you. These are my disclosures. Actually, this is the primary disclosure. So, I asked ChatGPT to say, what are some creative ways that I can make sure that she's super happy? I would say I'm not that worried about my future now, because if you look at these are low effort recommendations. In the last 15 years, I've thought of way more creative ways to make her angry. But she can't ever be angry at me because I gave her 2 beautiful kids. That was it. I just wanted to make sure that she remembers that I can go home today. So I'm going to talk about 3 things today. So in terms of fundamentally, how is AI going to change where we're at? I think the first thing is that AI does some things really, really well. And some of those are really basic tasks, but they're basic tasks that are critical to providing good care. And so I'll talk a little bit about that. And then my daughter, Sydney, she's just really special to me. She is very creative. And you can think, like when I watch her play, I think about the sort of really high cognitive load tasks that we do. And AI can help us do those tasks. So that's the second thing that I'm going to talk about. And then the third thing that I'm going to talk about is when my son plays with Lego, he's like, this is like his life. So I'm going to talk about the things that we can't do right now. That maybe as gastroenterologists, there are things that we would like to conceptualize that we just mentally or computationally can't, but AI can. And so those are going to be sort of the 3 segments that I'll talk about. So I'll start with this, which is day-to-day tasks that seem unbelievably mundane, but they are absolutely vital to actually being a good clinician. And I'll use this example. So this is an example of a disease called eosinophilic esophagitis. So we often say this is a disease called EOE. It's an allergic disease where your exposures to different foods and different aeroallergens in the air induces this really intense inflammation in your esophagus, the swallowing tube that connects your mouth to your stomach. We often say this is like an asthma attack of your esophagus. And when that happens, you can't swallow. When we put a camera down or an endoscope down, we see this really angry esophagus. And the diagnosis is made when we take biopsies of that esophagus. When we take biopsies, we ask our pathologists to count this very specific type of inflammation cell called an eosinophil. And the biopsies look something like this. So you can see that they come in different fragments. And when we blow that up, it looks something like this. And we ask the pathologist, well, I want you to count all of the eosinophils that are here. Not because I hate you, but because actually that number is really important. That number, if it's more than 15, helps us make the diagnosis. That number, if it's really high, tells us that maybe we're not doing a good job of controlling your disease. That number, if it's really low, tells us that actually you might be in remission. So that I'm asking them to count it not because I want to take up an hour of their time, but because it matters. That number matters to the patient and it matters to how we treat them. So each of these little dots could be an eosinophil. And you can imagine that if you wanted to count these, that's an unbelievably mundane task that requires some degree of precision and has some degree of consequence. The good news is that actually AI can do this way better than a pathologist. So this is an AI model that highlights all of the eosinophils in green. It can count those instantly. Not only that, it can count all of the other types of cells for you. So all of the red dots are the nucleus or the center part of the cells. although the blue dots are another kind of inflammation cell called a lymphocyte. But that model can do more than just count. It can then look at the different parts of the biopsy and tell us what parts of the biopsy are hot, what parts of the biopsy here in green are totally cold. That's scar tissue. That's scar tissue from having EOE for a long period of time. And in fact, if we ask our pathologists to score using our formal scoring systems for EOE, it can take them an hour to score this. That's an hour that they might not be reading another case, like, for example, a colon cancer case, which we'll talk about coming up. I showed you this is the biopsy, right? The last pictures I showed you were zoomed in. Well, where do we zoom in? And in fact, actually, our AI models are way better at differentiating what parts of the biopsy are abnormal, what parts of the biopsy maybe you don't need to look at. So this is a task where I think an AI assist can go a long way. I'll give you another example of a mundane task that maybe looks different with AI. And that's medical scribes. So I've started with a pathologist looking at a microscope. Actually, the most valuable interactions, I think, are probably you talking to me and me talking to you, right? But you've ever been to a doctor's clinic and you've seen them turn their back to you because they're typing on a computer and looking at a computer screen? That's not an interaction that gives you the same feeling as an interaction where you're engaged. I know that because if I'm on my phone and I haven't listened to my wife appropriately, I always listen. But listening and being engaged in listening is a little bit different. This is actually from 2024. This is well out of date. These are all these different AI scribe technologies that are listening to the conversation and can summarize that for both the clinician and for the patient. And that provides you potentially a background, like if you missed something during the appointment, that's something that you can go back to and provide clarity on. For a clinician, actually it provides you a much greater degree of flexibility in terms of being able to actually focus on the interaction and focus on the decision making rather than focus on the charting. And so I think when we think about the experience of going to a physician, taking away some of those background tasks and allowing them to both of you to focus on the interaction that matters is potentially more beneficial. So in the second part, I'm going to talk about this, which is AI can help us do mission critical, high cognitive load tasks, but they can do them better or help us do them better. So this example I'm going to use is an ounce of prevention is worth a pound of cure. And for us, colon cancer is one of the most important diseases that we try to diagnose and treat. As a plug, everyone should have colon cancer screening when you get to the right age. That right age depends on who you are. But for the most part, colon cancer doesn't develop overnight. Colon cancers take a long time to develop. They usually take 10 to 15 years to develop. And that means there's a long period of time in which we can intervene to try and find early colon cancers or early growths that can grow into a colon cancer. And that's everyone's favorite procedure, which is a colonoscopy. People who've had a colonoscopy laughed at that. So what we're trying to do is we're trying to find these early growths, these polyps, and take them off. So this is an example. This one is clear as day. You can see that growth that's growing in the bottom right-hand corner of the screen. What happens is we do a colonoscopy, we find those growths, take out a little loop, wrap it around. Don't worry, it's going to get way cooler. I heard an oh dear somewhere. And then we use a little bit of electricity and fry that off. And you know what? That never grows into a colon cancer. 10 years from now, that's just going to be normal, healthy bowel. Ta-da! Don't get that in rheumatology, do you? Now, I guess my question for you is, this is a high cognitive load task. You need to be able to find it, recognize it, take it off. There's a million things that we're thinking about when we do this. can AI do this better? And actually, I'm going to just skip ahead. I'm going to show you this video. The first polyp I showed you, anyone can find that. Watch this video. You tell me where the polyp is. Not so obvious this time, right? But I'm going to show you that same video with computer vision. So this is an AI model in real time that highlights for the clinician, actually, there is a polyp in that blue square. That's trained on millions and millions and millions of colonoscopies, such that it can recognize polyps, it can recognize even the microscopic patterns within those polyps. And in fact, actually, this is probably one of the areas where I think we've collected the most data. This is a review that has over almost 35,000 cases. And what we found was that actually, you know what? When we use computer vision, we find more. We find 20% more polyps. Those are things that can grow into something dangerous. It doesn't add that much more procedural time. It adds a half a minute to the procedure. But what's very interesting, and I'll come back to this at the end, is that some polyps are really bad and some polyps are meh. It's like my performance as a dad this morning. And even though the AI helped us find more polyps overall, the really bad ones, actually most gastroenterologists were just as good. And we have now AI vision procedures that can help us detect diseases, not just polyps. These are examples of an esophageal cancer, a very early esophagus cancer. And AI vision can help us map those out and determine with much greater precision what that could look like. So in the next couple of minutes, I'm just going to talk a little bit about, well, what about the things that we can't do? So these are things that we currently cannot compute as a human gastroenterologist, but an AI can, possibly. This is a disease that I study primarily. So this is a disease called inflammatory bowel disease. One of these conditions is a condition called ulcerative colitis. Very debilitating condition. Affects people primarily in the prime of their life, causes terrible rectal bleeding, abdominal pain, and diarrhea. When we do a scope for someone with ulcerative colitis, it's not just a polyp. It's not like just a little growth. Actually, this is a scope of someone who has ulcerative colitis. You can see it. There's ulcers, it looks hot and inflamed, and it does not look normal. If you were to describe this with words, it would take a lot more than just saying there's a bump there, right? Yet somehow we describe this with a score that is 0, 1, 2, or 3. Mild, moderate, or severe. And it highlights the fact that actually chronic diseases are complex. Our frameworks for thinking about complex diseases sometimes are very simplistic. Is it mild, moderate, or severe? That doesn't actually capture what someone is experiencing. So this is work done by one of my colleagues, Ryan Stidham. He's used to be at the University of Michigan, but he decided he wanted to live in warmer weather, so he just moved to Jacksonville to work at Mayo Clinic. And he said, well, a 1, 2, or 3 actually doesn't capture what someone looks like with ulcerative colitis. So he's developed this computer vision tool that maps out the entirety of the colon, gives you a score for every single frame within that bowel, and gives you a score that's much more broad and captures much more of the disease. And you can say, well, actually, at 15 minutes, there are different features than there are at 12 minutes, than there are at 7 minutes. And does that actually help? And the answer is yes. Because when we're trying to find new therapies that work, that help people, actually using a tool that captures more information and is much more sensitive allows us to find therapies that work more effectively and have more ability to detect change. Endoscopy, what I've shown you with the video, that's kindergarten stuff. What is really interesting is this. This is looking at endoscopy is one element of that informational piece. But the information that we have on a biopsy, the information that we have from your genetics, the information that we have from your microbiome, which is all of the different bacteria within your colon, That information we've never used clinically because we've never had the ability to do that. And AI is going to give us the ability to do that. And so to take all of those different kinds of information that we currently have no framework for thinking about, and translate that into something meaningful, I think is important. So this is an example using the microbiome. It's a major focus here at the university because I think we have one of the top microbiome centers in the world. Can the bacteria in your gut tell us something about you? And this is an area that we're interested in, is actually how does the bacteria in your gut tell us how well you're going to respond to a cancer treatment? They seem totally unrelated, yet somehow they actually are incredibly predictive of each other. And so being able to use that type of information, I think, will allow your gastroenterologist in the future to be much more precise than your gastroenterologist today. It's not all hunky-dory, so I'm going to end with this. This is on the cover of the Lancet Gastroenterology and Hepatology in October. So this is one of our major GI journals. And it looked at an experience in Poland. And they looked at the hospitals that were participating in a clinical trial where they had the polyp detection tool that I showed you earlier. What happened? Well, you would think maybe the gastroenterologists got better because they're seeing more polyps. Actually, what's interesting is the exact opposite. The gastroenterologists got much worse. In fact, they became de-skilled even within the period of 2 years. They started finding less and less polyps when they were doing it on their own because they all of a sudden didn't rely on the cognitive skills that they had or had practiced. They were relying on a little blue box to pop up on the screen. And that, I think, maybe is where I will leave you, is that, May talked about us being in this revolution right now, which I think is true. But where we go really depends on what we want to do with this. There are lots of pitfalls, as May outlined. And the future and the path of how this influences your interactions with your physician, how it influences our interactions with patients, I think that still is for us to decide. And hopefully you'll think of a very bright and happy future where my wife is also happy. Thank you.
Great. Thanks, Chris and May, for the awesome presentations. We'll now open the floor for a Q&A period. We will alternate between questions from Slido and our live audience members, and we'll do our best to answer as many questions as we can in the time remaining. And please note that we can't answer patient-specific questions or provide individualized medical advice. So while we wait for someone to grab the mic to pass to the audience, I'll take a question from Slido, and this kind of relates to what you just were talking about, Chris. But someone mentioned that there's a CBC was reporting on another study on radiologists that found that they became de-skilled when using AI. So if this is true, who will properly train AI?
Yeah, it's a good question. So the training of different models, I think, is highly variable, right? And the endoscopy example for ulcerative colitis that I gave you is a good one. There's a dozen endoscopy models that can tell you if a colon looks normal or not normal. And they're trained in different ways. They're trained either primarily on existing data. And the annotations around that, I think for most model training, we spend a lot of time and effort in developing that. So I think that the risk there is probably mitigated. The bigger risk is when it goes into day-to-day practice and in real life settings, what that looks like, and who takes on that responsibility. Ultimately, all of that responsibility falls on patients, right? So I think one of the things we have to decide is, does an AI model help make our physicians better? To what degree does that happen, and to what degree of confidence you have in that? Right now, I think we're in the early days, but my hypothesis is that in 15 years, everyone will say that they would prefer to have an AI assist because it can capture, even though the clinician may become, there is a risk for de-skilling. The ultimate goal for you is to get the best care possible, and I think that is helped with an AI model.
Thank you. If someone in the audience has a question, we'll get you a mic if you just raise your hand. If not, I'll move on to the next.
Okay.
Yeah. You use AI and a computer screen in your office with patients to sort of walk them through what it is they're doing so that you're having kind of a triad relationship with you and the patient and AI?
Yeah, so that's a good question. So the example that Chris used, he talked about AI scribes. That's something that a lot of hospitals are integrating now. Here with Alberta Services, they are currently developing their own version because of privacy, like patient data. And so in the future, we're going to see more and more of it integrated into practice. There are some private practices that are already using AI quite a lot. Some of my colleagues who are seeing rheumatology patients are using it, but there are some restrictions based on where you work.
Yeah, and I think I totally agree with that. The other comment I would make is that there's some obvious examples, like ChatGPT is a really obvious example, but there are much more subliminal examples of how we use AI intelligence even within our current model of care. So, for example, within our electronic health records, there are a number of alerts that get set up. They're safety alerts. And I think that the aims of those are to prevent us from doing something that inadvertently might be hurtful. Prescriptions are a good example, right? If you're prescribed a medication that has interactions with something else that you don't think about or recognize, there are a number of already existing backup systems that help with optimizing what therapies patients go on when they get admitted to hospital, making sure that all the discharge, like those types of automated alerts, they're based on data that's driven from within Alberta Health Services. So that's maybe more subliminal than true chatbot generative AI.
And there are a lot of labs that actually use AI techniques that are integrated into the machine. So you wouldn't know unless you are the technician using that. But there are some, I can think of a few examples right now where AI automatically interprets the test result for the lab technician who then enters it into your chart. So there are things that are already integrated and utilized on a day-to-day basis.
Thank you. I'll kind of combine the next two from online. So with the integration of AI into medicine, what happens like to the hands-on treatments? How is that handled? And then if there is an incident that would typically face malpractice to your person, who will be responsible if it's any AI?
I can tackle the surgery question first, maybe. So, I think the technical aspects of surgical care or medical care, right now, most of that learning happens in an apprenticeship type fashion, right? We have this saying that you watch one, see one, do one, or watch one, do one, teach one, actually, right? English is my second language. Idioms are really hard. But that's the process of training, right? Is that you see one, then you're taught how to do one, then you do one on your own, and then you teach someone else how to do one. And is that going to go away with AI? I actually think probably the opposite is true, that our ability to teach skills is going to go up. And I'll give you an example of one. So ultrasound is a really important part of our practice in gastroenterology. Ultrasound uses sound waves basically on a probe to look at the inside of your body. The performance of that technology is dependent on how good you are at holding the probe and using the probe. and I have 2 left feet and hands that don't work well. So for me, like that was a skill I would never be able to learn. We're working with a Canadian company right now to develop an AI training technique where the AI is watching you and can give you real-time feedback as to your technical skills, as to how it pertains to your technical skills. And so that is an example where I think those hand skills take time to develop. Being able to provide more targeted feedback in that development process, I think, gives you an ability to accelerate how quickly you can become proficient in hand skills. I don't think those are going to go away. I think actually they're going to get better.
Mm-hmm. I think I can sort of answer that second question about, who's responsible for these AI technologies. So a personal example is I'm currently trying to develop an AI technology that can interpret a test called an ANA. Some of you may have heard about it. It's basically used to screen for autoimmune diseases, and there are 32 different results that you can get, and in different combinations if you have multiple ANA results. Very technically challenging, time-consuming. For me to be able to bring that tool, I still have to get it Health Canada approved, FDA approved. I have to show that it works, validate it. So I still have to go through the vigorous process of making sure that it is a reliable tool and it is safe for patient use. So I think we still, even though these tools are now AI-based, the expectation is still there to make sure that we are putting patient safety first. So right now we're testing it out, and it's a test use only. We put out the disclaimer, that should not be used as a tool to make any medical decisions. It's currently undergoing testing, so that we put that disclaimer out there. But certainly, I think this kind of tool, AI-based or not, still has that same level standard that they have to meet. So that's why it's kind of important if you're hearing about these tools to make sure it's actually gone through that process. It's not just like in the testing phase, because I think that some people are trying to speed up the process of adoption. So make sure you read the fine print. What stage is it actually at? Has it been government approved? And that's really important, especially as lots and lots of tools are coming out right now. We can't even keep track.
We can take a question from others.
Hi, thank you so much for the presentation. My question is, I'm wondering if you have any thoughts about whether or not the use of AI or the development of AI in healthcare is going to help to drop the cost of healthcare in future, or I guess make the cost of healthcare continue to rise?
I would say the prediction comes with an asterisk. My own view is that actually I think in the short term, we're going to see an exponential increase in cost because we will be able to do things that we haven't been able to do in the past. So a good example, like the radiology example is good, right? A radiologist with an AI assist can potentially read far higher volumes than what we have been able to read in the past. And if we're able to glean more information from images than we have been able to before, I think our utilization of that will go up. The tipping point will become when we can treat people in a much more effective way, that the downstream costs to the system go down. And the downstream costs for us, I think the big ticket items are requiring hospitalization, requiring surgery, requiring big interventions that are extremely costly that may or may not work. Like to show that those things go down in the future, I don't think we're going to get there in the immediate term. So I think it's going to be up first before it comes in. And I'll be out of a job before then, so it'll be okay.
Next question on Slido is, will AI help pick the right medication for the patient for better outcomes? And then the question we got previously was also, if AI can pick great medications where we used to have to go to a pharmacy, a pharmacy.
I think that's one of the, applications of AI that is getting a lot of attention right now is precision medicine. So I think Chris kind of talked about this at the end where he showed that circular chart with all the different types of data that you can now use to answer questions about your patient. And one of those questions is, what medication should I use? And right now in rheumatology, we don't have that many options for our patients. It's almost like the same 5 drugs that we use for lupus, kind of guessing which one might work. We have some guidelines that we follow. But if one medication doesn't work, our next option is to kind of move down the list. So AI is now able to use genetic information, protein information, their demographic, all of that information that Chris showed you to help pick a pathway in the immune system that is abnormal and then try to find a drug that targets that pathway. That's the future of precision medicine and picking the right treatment. So I definitely think that is in the near future. And we weren't able to do that before because that was a lot of information for us to process using traditional statistics. We could do it, but it would take 1 million years to process that information. Now the supercomputers can do all of that in a weekend. Something that would take months and years. It takes my AI person just a few hours over the weekend. They can run that, scan the whole database, and find an algorithm or a drug. So we can do that much faster because of these supercomputers. And so whether or not, I guess the question is something about pharmacy, like whether or not people, I think there's still a role, like the pharmacist isn't just prescribing the drugs. I think that, right now my brother's a pharmacist, so I shouldn't scare him on anything. But I think right now we're not there yet. We don't have that kind of power to do that in most diseases. Would you agree? Like, I think we're getting close for some. But I would say there's still a role because pharmacists do much more than just dispensing the medications. But yes, there are certain things that I think, as we explained, AI will be better at and eventually replace. Yeah, that would be my answer. I don't think anything else to add to that.
I think the only comment I would make would be about new drug discovery. Almost all of the, at least sort of major pharma companies now, in terms of when they're looking for new therapies for discovery, almost all of that is based on AI-driven models. So the process for developing a drug from starting out from the bench all the way to getting it approved is extremely long and costly and onerous. And we often say that less than 10% of drug candidates actually make it, right? So trying to turn your win rate from 5% to 25%, I'd say that's a huge investment from pharma right now, is to try and change that win rate over time.
Yeah, I think
that's all AI based.
I think one of the biggest AI tools that's been discovered is called AlphaFold. You may have heard of it. And basically, it's been able to find new drug targets much more quickly than we have traditionally, and it's able to actually skip many of the phases of getting the drug to market because it's been so good at finding these drug targets. So now these drugs go right into the early phases of clinical trials, kind of skipping a bunch of steps. And now we're hoping that it can speed up the discovery process to the point where we can get these drugs years before that we would have expected it. So skipping major steps to get to the patients much more quickly because of these AI tools. So it's called AlphaFold. It's been one of the biggest AI milestones in recent years. It's been pretty cool.
Oh, that's really cool. We can take another question from the audience.
Thanks. Have you seen your patients in the last year really asking more and more difficult questions, or questions beyond what a patient who doesn't really have medical training would normally ask in your careers? And also, do you think they're overdiagnosing themselves? And are you seeing that?
My patients always ask difficult questions. Yeah, I don't know. I think I have encountered patients who would admit that they have looked something up, or ChatGPT told me this, what do you think of that? So I have encountered that more often in the past year. I don't know about you, Chris.
Yeah, I mean, before Dr. ChatGPT, there was Dr. Google, and before Dr. Google, there was Dr. Yahoo, and then before Dr. Yahoo, there was Dr. AOL, right? So, but I think the advantage is that the accessibility of that information is better. And I think overall, it is better for patients because it's that data and that information is owned by you. It's not owned by anybody other than. And the advantage of it's the equitability of it. Like 15 years ago, you think about, there's some degree of health literacy sometimes that comes into being able to ask very pointed and very relevant questions. And I think AI will make that bar more equitable for everyone to access, which I think is good.
Hi, thank you very much for your presentation this evening. I'm going to kind of flip the subject and talk about, or ask you questions about, are physicians required to let us know when they're using AI for their diagnosis, and what parts of your practices are using it? My husband and I have already had incidences with speech to text in a physician's office where the information that was taken was actually incorrect. It was for the wrong person, and the information was put on the wrong person's record, and medications followed, and we've been having a very difficult time in removing that. And so I see a lot of really great potential for AI, but I think there should still be some hesitance in using that technology, and to what extent you're using it, and how much confidence you put into the responses that you receive. And I think from a personal perspective, and having navigated the medical system since I was 10 years old, I see less hands-on physically on the patient and asking those questions. Sometimes we can get really great information from patients just from conversation rather than using medical tools as a diagnostic. We've come a long way, but there's something still to be said for having that conversation with a patient. And you had said earlier about will we still have physicians? I need to know your personal perspective on some of that, because we've had some really challenging issues. And how is the medical system going to navigate through all of that? Do you feel confident that we'll be able to get good, solid answers, and we will believe our patients, and that we will go beyond just the analytics and use our logic as well?
Maybe I can start. My own view is that it's a technology that we should use to be the best version of ourselves. And I think the risk is that it's a technology that becomes ourselves. And I would say that I think you hit the nail on the head, right? That this job it's a people business. It's a job that requires interaction. And if we can use it to leverage that and to maximize the actual interaction, then I think that's a win. I think if it replaces the interaction, I think that's a loss.
There's a really good video where they interview the founder of OpenAI, and he talks about his fears of AI in the future. And one of them is AI will be so integrated, we don't even know, if it's actually replacing our thinking, and the implications of that. And it talks about all these other things like somebody starting a war using AI it goes a little bit extreme, but I think one of the fears is that we don't even know that it is changing the way that we think, without us even knowing. I think, I gave the example of some of the hospitals that, you walk in and they take the information and then apply it to the next patient, that kind of model. I think patients should know about that, especially if some of these AI algorithms are right now have not been approved, have not been tested out. I think definitely at this stage, if they're not ready, then patients should know, right? They should have the option of saying, I don't want that algorithm to be applied to me to decide which medication I should be taking. I don't want that to be used in a model that will decide whether or not I get that CT. So that I think exactly, it needs to be disclosed and have a discussion, because the technology is not yet. So certainly I think that consent needs to be there. That's my personal view. Technology. Yeah, so I think right now it's how others are, like if they're using AI scribes, if physicians are telling patients, my personal take on it is that they should tell the patient that it is being used, but I don't know if everybody's following that as well.
So for most of the AI scribe technologies, that you do have to provide consent for them to use that.
I know that they're trying to develop more of these guidelines and rules continuously just to keep up with how fast the AI is developing. So I guess, we just all have to be aware of what are the current rules and guidelines, even as patients. I think there was another question closer to the front. Yeah.
I was just going to say that sometimes AI is being used and even the physician doesn't know it's being used. Like TELUS was taking all of the information out of the family physician's EMRs and using it to come up with all sorts of different
That's right.
algorithms, and the physicians did not know about this.
No one reads the disclaimers before they sign I accept at the bottom.
We're almost out of time, but I'll take the last question from online because it's come up a few times. But in your opinion, do you think AI will completely take over medical careers? How much harder do you think it will be to become a doctor in the future? And do you think younger people should still go into medicine?
We have this discussion actually quite a lot, because we have to think about, the future for like our children, what they want to, what careers they should choose, which careers will be taken over by AI. So we actually talk about this a lot, and I think there will be some careers, as Chris talked about, some of the ones where the tasks are more repetitive, doesn't take as much, cognitive load, that will be replaced. I think radiology, a lot of people actually expected radiology to completely be taken over by AI. But what radiology has done really, really well in the last 10 years is actually to control what AI technologies get approved by the FDA. So you'll see on the list of 1,000 things that have been approved, a lot of them are radiology and cardiology because they want to control what is approved so it doesn't entirely take away their specialty. So that's one view on it. Anything to add, Chris?
Yeah, it's a great career. And the part about the career that I do think will never go away is the comment that was made earlier, right? Like the best part of the career is the you and me part of it. that I think will never go away. And I think that really special, it is a really special, and sacred maybe isn't the right word, but English is my second language. It really is a special and sacred relationship, and I don't think that AI will ever replace that. So yes, still apply.
Well, thank you. We're out of time for tonight, so we'll wrap up here. But I want to thank everyone for attending tonight's lecture, and huge thanks to our speakers. I'd also like to thank our collaborators, Buxa, AstraZeneca, the Cumming School of Medicine, and the Calgary Public Library for their continued support. We hope that you enjoyed this lecture and invite you to join us again on February 2nd for our next mini-med school lecture. For those of you here in person, please join us to connect over refreshments in the Hippocrates atrium. And for those of you online, thanks again for attending and have a great evening.